So we are going to discuss bronchial asthma. We are going to discuss uh, classify drugs used for treating bronchial asthma. What questions we are going to discuss in this session? I'm going to talk about that first. So we are going to talk about classify bronchial asthma. Sorry, drugs for bronchial asthma, mechanism of action, therapeutic use, adverse effects of salbutamol. Okay, we are going to discuss about salbutamol. Fine. Then we are going to talk about mechanism of action and therapeutic uses of anti-emetic drugs. And then we are going to talk about therapeutic uses, adverse effects of proton pump inhibitors, treatment of myasthenia gravis. Not this one. Not this one. We'll cover in another session. Uh, then we are going to talk about drugs used in acute gout, antihistamines, therapeutic uses of alpha blockers. Why alpha blockers? Not alpha blockers. No, not in this session. ANS, CNS, another session. Okay. Mention types of antagonism with examples. Okay. So we are going to talk about these questions and also anti-angina, classify anti-anginal drug, describe mechanism of action, therapeutic uses, adverse effects of nitrates. Next, therapeutic use and adverse effects of corticosteroids, furosemide. Okay, so we're going to talk about all these questions in a very short span of time. So let's begin without wasting time. Okay, so let's talk about first asthma as our topic for today. Okay, let's talk about asthma. Let's talk about asthma. Let me fix my mic. Oh my god, something has happened. Once. Okay. To adjust my mic so that. Oh my god. Okay. Some issue. I think this should work. Okay. So let's first talk about bronchial asthma. So classify bronchial asthma. So for classification of bronchial asthma, you guys know that asthma from the pathology point of view, that there is it is a COPD. It is a COPD, right? COPD, that is chronic obstructive pulmonary disease. Here the upper airways, large airways get narrowed, okay, because of constriction of the bronchial muscles. So let's talk about it. Classification. So drugs used for bronchial asthma. Drugs used for bronchial asthma are, we use bronchodilators because there's a constriction, and leukotriene antagonist because it's a type 1 hypersensitivity. So with leukotriene antagonist, mast cell stabilizers, corticosteroids, and anti-IgE antibodies. So you know from the uh, topic that bronchodilators are salbutamol, that is beta-2 sympathomimetics, methylxanthines, and anticholinergics. Leukotriene antagonist, montelukast, zefirilukast, and mast cell stabilizer, sodium chromoglycate, ketotifen, and corticosteroids, systemic and inhalational, and anti-IgE antibody. Talking about bronchodilators, beta-2 sympathomimetics. Beta-2 sympathomimetics are salbutamol, terbutaline, bambuterol, salmeterol, formoterol. Methylxanthine, theophylline, aminophylline, choline theophylinate, hydroxyethyl theophylline, and doxophylline. Anticholinergics, ipratropium bromide, tiotropium bromide. So let's talk about bronchial asthma in detail. Okay. Drugs used in bronchial asthma. In bronchial asthma, there is an impairment of airflow due to contraction of bronchial smooth muscles. bronchospasm, swelling of bronchial mucosa, mucosal edema, and increased bronchial mucosal secretion. This is inflammation and hypersensitivity response of airways. Several factors may precipitate attacks of asthma in susceptible individuals, such as allergy, infection, and psychological factors. The airway obstruction in asthma is mainly due to the release of mediators from sensitized mast cells in the lungs. Example: histamine, 5-HT, serotonin, prostaglandins, leukotrienes, LTC4 and LTD4 proteases, PAF2, etc. The patient may have shortness of breath, wheeze, tightness in the chest and cough. Bronchial asthma may be either episodic or chronic. Classification of antihistaminic drugs: bronchodilators, leukotriene receptor antagonists, mast cell stabilizers, glucocorticoids, anti-IgE monoclonal antibodies. Sympathomimetics and all we are going to talk in detail. Okay. I think I'm not comfortable with using the mic, and even charging is not there. If I keep it far away, then there's a chance that my voice will be not audible. Okay. So I'm worried about it. Okay. So I'm not sure that I will be perfectly audible or not. What should I do now? Okay, so let's see. I'm adjusting it. 1 minute. Will be okay. Oh yeah, charging is happening. Okay, so let's start. So talking about bronchial asthma. Okay, so let's talk about bronchial asthma. I think I am perfectly audible. Okay, and my phone is charging or not? Yes, it's on charge. Okay, so everything all right. So let's talk about bronchial asthma. So guys, this chapter is of utmost important, and whatever chapters I'm going to discuss, the respiratory, CVS, autocoids and all, these are highly important. So without wasting a single second, let's start about bronchial asthma. So you know bronchial asthma. Uh, let's first in minutes I'll give you the overview and then we'll talk in detail. Okay, from KDT. So drugs used in the treatment of bronchial asthma. So in bronchial asthma, there is an impairment of airflow due to contraction of bronchial smooth muscles, that is bronchospasm, swelling of bronchial mucosa, mucosal edema, and increased bronchial mucus secretion. There is inflammation and hyperresponsiveness of airways. Several factors may precipitate attacks of asthma in susceptible individuals, such as allergy, infection, and psychological factors. So the question will be like a patient. The scenario case scenario will be like a patient is there, and she was having infection in the past, and now she is having airway obstruction. That is lots of bronchial secretions and mucosal edema, and she's restless and unable to breathe. So the way airway obstructed is in asthma is mainly due to a release of mediators from sensitized mast cells. 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 So it is because of release of mediators of sensitized mast cells in lungs. Example: histamine, 5-HT, serotonin, prostaglandins, leukotrienes, protease, PAF, etc. The patient may have shortness of breath, wheeze, tightness in the chest and cough. Bronchial asthma may be either episodic or it can be chronic. It's not just episodic; it can be chronic also. So the it is due to sensitization of mast cells in lungs, and when mast cells are sensitized, they release histamine, serotonin. That is serotonin is 5-HT, guys. 5-HT serotonin, and prostaglandins, leukotrienes, LTC4 and LTD4, proteases and PAF, etc. The patient may have shortness of breath, wheeze, tightness in the chest and cough. Okay, talking about classification of antihistamic drugs, so there are bronchodilators, leukotriene receptor antagonists, mast cell stabilizers, and glucocorticoids. And anti-IgE monoclonal antibody in attack will give, that is omalizumab. 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 So talking about this, so this session is going to be a more of a audio than the visual. So try to focus on the audio. So classification antihistamic drugs, anti-asthmatic drugs. So they are bronchodilators. So first of all, you have to release the constriction by dilating the muscles. So we use sympathomimetics. Sympathomimetics, parasympathetic in the lungs or respiratory, that for constriction. So for sympathetic, we give the dilation. That is selective beta 2 adrenergic agonist. Agonist we give, that is salbutamol and terbutaline. Salbutamol and terbutaline are short acting, and bambuterol and salmeterol and formoterol they are long acting. Methylxanthines are theophylline, aminophylline, etophylline and doxophylline. Anticholinergics, these are ipratropium bromide and tiotropium bromide. These are anticholinergics. Leukotriene receptor antagonists, zafirleucas and monteleucas and zilutin. Mast cell stabilizers, sodium chromoglycate and ketotifen. Glucocorticoids, inhaled glucocorticoids and systemic glucocorticoids. Inhaled glucocorticoids, these are beclomethasone, budesonide, fluticasone and cyclisonide and flunisonide. Systemic glucocorticoids, hydrocortisone, prednisolone and methylprednisolone. So try to remember. How to remember? I'll give the trick. So bronchodilators. Bronchodilators, you have sympathomimetics. Sympathomimetics means same, they work as sympathetics, like uh, sympathetic nerves. They release the adrenaline. Okay, so similarly they act. So they are agonist, beta 2 adrenergic agonist, because beta 2 for lungs, beta 1 for heart. So here we want beta 2 selective. Okay, not, we don't want to act on heart, we want to act on lungs, so, and bronchus and all. So selective beta 2 adrenergic agonist we give, and what we give in that, salbutamol and terbutaline. These are short acting. Bambuterol, salmeterol and formoterol, these are long acting. Methylxanthine, theophylline, aminophylline, etophylline and doxophylline. These are methylxanthines. Anticholinergics, ipratropium bromide, tiotropium bromide. Leukotriene receptors, zafirleucas, monteleucas, zilutin. Mast cell stabilizers, sodium chromoglycate and ketotifen. There are 5 actually. Glucocorticoids, inhaled and systemic. Inhaled one is budesonide, beclomethasone. Systemic, hydrocortisone, prednisolone. Anti-Ig monoclonal antibodies, omalizumab. So try to remember this. First let's see the mechanism and then we'll understand. Okay, mechanism of action. There are sympathomimetics. Sympathomimetics means what they do, They're sympathomimetics. Sympathomimetics means what they do, they act on the beta 2 receptors, because we are taking selective beta 2 agonist. So they act on beta 2 receptors, they increase the cyclic AMP, and because of increased cyclic AMP, what will happen? There is a bronchodilation. They inhibit the release of histamine. Histamine release the inhibit of histamine. Histamine is SRSA. They release the inhibit the release of histamine. If there is no histamine, there is no bronchoconstriction. And SRSA, LCT4 and LCTD4, these are leukotrienes from mast cells. They promote mucociliary clearance. So mucocelia, ciliary action will be there, and clearance of the mucus. So sympathetomimetic, they act by stimulating beta 2 receptors in bronchial smooth muscles and mast cells. Okay. So mast cells, they increase cyclic AMP, so there is bronchodilation, and there is decrease in the release of histamines and leukotrienes, that is LTC4 and LTD4. Selective beta 2 adrenergic agonists, they are most effective bronchodilators for mechanism of action. You have seen it, okay. So beta 2 agonists, salbutamol and terbinafine. Salbutamol, you know, these are short acting. They are selective beta 2 agonists on inhalation. They are given as inhalers. They have a rapid onset within 1 to 5 minutes and short duration of action. They are useful for acute attack of asthma. Route inhalation. Other routes of administration are oral, IM, and IV. You can give oral also, IM also, IV also, but inhalation is fast acting, and 1 to 5 minutes, within 1 to 5 minutes it will show its action, and short acting could give it for long. Okay, talking about salmeterol, you know salmeterol. Okay, salmeterol is long acting. Long acting selective beta 2 agonist. It is preferred for moderate to severe persistent asthma, not suitable for acute attack as it has a slow onset of action. Route is inhalational. Talking about formoterol, you know, long acting, this selective beta 2 agonist. Selective beta 2 agonist, it has a rapid onset of long duration of action. Formoterol in combination with low dose inhalation glucocorticoid is preferred for relieving symptoms of asthma. It has a rapid onset for long duration. Formoterol in combination with low dose inhalation glucocorticoid is preferred relieving symptoms of asthma. You you should never give a patient beta antagonist, because for asthma patient I'm saying, because beta antagonists, what they do, they constrict the bronchial muscles, so that's why it's contraindicated, and that will also precipitate asthma. So never give that. You always give them agonist, beta agonist, especially beta 2 agonist that acts only on respiratory part, bronchus, lungs, and all. Okay, so what they do, they increase the cyclic AMP so that the mast cells they are inhibited and they do not release histamines and leukotrienes, LTD4, LTC4. Okay, so because of this, the bronchodilation will be there. They are well tolerated when inhaled. They may cause tremors, tachycardia, palpitation, hypokalemia, and really cardiac arrhythmias. So, what are the side effects? They can cause tremor, because the beta 2, the tremors and the tachycardia, palpation, hypokalemia, and really cardiac arrhythmias can also be there, because if there is overdose, then they can also act on the heart. Bambuterol, it is a prodrug of terbinafine. It is administered orally. Once daily dose is used, it has long duration of action, so it is produced. So Bambuterol is a prodrug of terbinafine. Talking about adrenaline non-selective sympathomimetic. It produces prompt and powerful bronchodilation by acting through beta 2 adrenergic receptors. Its use has declined because of its dangerous cardiac side effects. So when the patient is having acute bronchial attack, then some patients can be given adrenaline, but adrenaline should be given only when the patient heart is in bradycardia and all this there. Then only you can give adrenaline. But if you give adrenaline, it will relieve bronchial constriction by doing its bronchial dilation, by acting on beta 2 adrenergic receptors, but the most dangerous side effect is cardiac arrhythmias. The cardiac side effects can be there. Talking about methylxanthines, methylxanthines is also under the category of bronchodilations. So, use of methylxanthines in asthma has markedly diminished because of the narrow margin of safety. Because of their, am I live? Okay. Because of narrow margin of safety. So, methylxanthines, use of methylxanthine in asthma has markedly diminished because of the narrow margin of safety availability of better antihistaminic and anti-asthmatic drugs. Selective beta 2 agonists are the good one, and inhaled steroids the good one. Because methylxanthines, so that is theophylline and aminophylline, what they do is they inhibit phosphodiesterase. When they inhibit the phosphodiesterase, there is cycling AMP increase, and bronchodilators and inhibit the release of histamine and SRSF from mast cells, improve mucosal clearance. So the phosphodiesterase wala thing is increasing cyclic AMP, but phosphodiesterase inhibition can lead to some other side effects. So methylxanthine inhibit phosphodiesterase, thereby preventing degradation of cyclic AMP and cyclic GMP. Cyclic AMP. Methylxanthines inhibit phosphodiesterase, thereby preventing degradation of cyclic AMP and cyclic GMP. So methylxanthine they inhibit phosphodiesterase, so there is a prevention of degradation. So this results in accumulation of intracellular cyclic AMP in some tissues. Cyclic AMP, methylxanthine is a competitive antagonist of adenosine receptors, which also result in bronchodilation. The competitive antagonist of adenosine receptors. Pharmacokinetics, methylxanthine is well absorbed orally. You can give them orally, and parenteral administration. Okay, food delays the rate of absorption of theophylline. They are well distributed all over the body. They cross placenta, blood-brain barrier, metabolized in liver, and excreted in urine. They cross all the blood-brain barriers, placental barrier, everything. So theophylline is poorly water soluble, hence not suitable for injection, available only for oral. Aminophylline water soluble but highly irritant, can be administered orally or intravenously, slowly you have to give. Etophylline, it is water soluble and can be given orally, IM, IV routes. Doxophylline, doxophylline methylxanthine derivative, orally administered once or twice daily, less likely to cause GI or CNS side effects. So doxophylline, it is also methylxanthine derivative. Adverse effects, narrow margin of safety is there. They can cause tachycardia, they can cause palpitation, hypotension, sometimes sudden death due to cardiac arrhythmias. So because there is a chance of cardiac arrhythmias, we never give methylxanthines to cardiac patients. Okay. Methylxanthine potentiate the effect of sympathomimetics by bronchodilation, beneficial effect, and cardiac stimulation, that is a harmful effect. So phenytoin, rifampicin, phenobarbital, theophylline, they are enzyme inducers. So never give phenytoin with theophylline, rifampicin with theophylline, and phenobarbital with theophylline, because the enzyme inducers, they induce the enzyme, hence they accelerate the metabolism of theophylline and decrease its effects. If you are giving rifampicin with theophylline, then theophylline, it will not act. The patient will be in attack. Cimetidine or ciprofloxacin, erythromycin with the theophylline, because the enzyme induces potentiate the effects of theophylline by interfering with its metabolism. So cimetidine, ciprofloxacin, erythromycin, they can the enzyme inhibitors, so that the theophylline will be for longer time in the patient's body, and it can cause cardiac side effects. Uses of methylxanthine, bronchial asthma, and COPD. Um, Theophylline is used an additional drug in moderate or severe bronchial asthma, apnea in premature infants. Aminophylline caffeine is apnea in premature infants. There is apnea. The child is cannot not able to breathe. The infant is not able to breathe. So aminophylline or caffeine is used intravenously to reduce the duration of apnea episodes. Caffeine is safer than aminophylline, that's why caffeine is given. Talking about anticholinergics, ipratropium bromide, tiotropium bromide are atropine substitutes. They selectively block the effects of acetylcholine in bronchial smooth muscle and cause bronchodilation. They are working just like atropine, and for atropine toxicity, we give antidote physostigmine because it can enter the blood-brain barrier, but not neostigmine. So that's for atropine poisoning. So you know that the ipratropium bromide, tiotropium bromide, the anticholinergic, so they work same as the atropine. So they selectively block the effects of acetylcholine in bronchial smooth muscle, cause bronchodilation. They do not affect mucociliary clearance. They have a slow onset of action, less effective sympathomimetic drug in bronchial asthma. These anticholinergics are preferred bronchodilators COPD and can also used in asthma, bronchial asthma. They are administered by inhalation route, act primarily on larger airways. Tiotropium is longer acting and more efficacious than ipratropium bromide. Combined use of ipratropium acts on larger airways with beta 2 adrenergic agonists act on bronchiolar smooth muscle, produce greater and more prolonged bronchodilation. Different mechanism hence used in severe asthma. So anticholinergics, they are administered by inhalation route. Give them by inhalation route, and they act primarily on larger airways. They act primarily on larger airways. Tiotropium is longer acting and more efficacious than ipratropium. So they are administered by inhalation route. Give them by inhalation route. Give them by inhalation route, and they act primarily on large airways. Tiotropium is longer acting and more efficacious than ipratropium. So they are administered by inhalation route. Anticholinergics act primarily on larger airways. Tiotropium is longer acting and more efficacious than combined use of ipratropium with beta 2 adrenergic agonist act on bronchoscope muscle.